So in order to address your question, I would say first that today we have some biomarkers that can tell us whether the patient will more likely benefit from treatment with immunotherapy, either PD-1 or CTLA-4 or not, mostly PD-1 or PD-L1. However, these biomarkers so far didn't show a very reliable way to really stratify between responders and non-responders. And what we actually identified is that there is a 10 protein signature. That means 10 different proteins that are changed in the blood circulation of patients that are treated with immunotherapy, either anti-PD-1 or anti-CTLA-4, or the combination of both in melanoma patients. And based on these signature of protein, we can distinguish between responders and non-responders, where the area under the curve showed 0.84 a value, which means that we, in about 85%, can suggest whether the patient will whether the patient will respond or not to the therapy, where the sensitivity is about 0.93, suggesting again that this method may be a very powerful method to stratify between responders and non-responders. So basically, the work was done is to distinguish take these proteins, the different proteins that we identified, and to show how, when we look at this signature, we can now distinguish between responders and non-responders. That was the first part of the study. And the second part of the study was to look at the overall 1,000 proteins that we looked at. And in the case of the melanoma actually study, we looked at about 400 proteins, and we looked at the differences in this protein, and based on the changes in the proteins, we could suggest what type of biological processes happened in the patient's body in response to the treatment. As I mentioned at the beginning, these biological processes are sometimes pro-tumorigenic. We found, for example, angiogenesis biological pathway, or metastasis biological pathway, or proliferation, or inflammation, and so on and so forth. And when you look at these biological pathways in different patients, you can now suggest whether the patients, the reason why the patient does not respond to the treatment is because of a specific biological pathway that happened in this patient. And when we know that this is the case, we can identify the driver protein, the upstream protein, that from this protein, this biological pathway is actually occur. And based on this, we can now even suggest what would be the combinations of the treatment that this patient can go through in order to benefit from the treatment. So patients that usually do not respond to the treatment of immunotherapy, maybe we can suggest, based on this platform, a combination therapy based on the clinical studies that are done today in order to identify what would be the right combination for this person. So we improve, I would say, or we're trying to improve precision medicine and oncology, at least with immunotherapy, based on this, on the finding of this particular study, where we actually do it not only in melanoma, but also in other indications except for melanoma. So one of the things that we really found is that the changes in the protein that I mentioned before and the signature of proteins that we see suggest that there are some biological pathways that can stratify between patients that respond and do not respond to the treatment. In fact, what we found really interestingly is that the majority of the pro-tumorigenic biological pathways were found in the non-responders, whereas in the responders, we found almost no biological pathways. And based on that, we could now say what are the specific biological pathways that can suggest that patients do not respond to the treatment, and then suggest a combination treatment, as I mentioned before, that will improve the outcome of the therapy. So let's get an example. Let's say patients come to the clinic and get immunotherapy treatment and is doing the host response profiling platform. And based on the host profiling platform, we can predict whether the patient will benefit or will not benefit from the treatment. And now let's say that the oncologist will say that maybe the patients no longer respond to the treatment after a while, and the oncologist wants to try another treatment or another combination with the immunotherapy. Today, the way it's done, it's, I would say, arbitrarily or empirically or based on gut feeling of the oncologist to choose what would be the right combination for the patient, at least in melanoma. And what we actually suggest here, that maybe looking into the host response profile and looking at the proteins that are generated in response to the treatment as we do, we can actually now suggest what would be the right combination for the treatment. And this way we harness the host response profile in order to benefit the patients, not only as a predictive biomarker, but also as an actionable way to improve the treatment later on in the patients. So that's the idea of the host response profiling.